Lovely. I think we're ready to go. So hello, everyone, and Falcha. My name is Ahmed, and I'd like to welcome you to the webinar on dementia and dentistry today, hosted by the Irish Society for Disability and Oral Health. This is our second of a series of webinars running throughout the year. If you missed the first one, you watch the recording on our website at ISD, Irish Society for Disability and Oral Health .ie. I can link it in a second. I suppose just to preface this webinar, caring for people with dementia is not uncommon in Ireland, as all of you know. The incidence is over 1% in the Irish population, and it continues to rise with our aging population. So this topic is obviously very important for Irish dentistry in order to prepare us for the future. And I'm glad to see so many people here. We had a very good turnout of registrants for this webinar, because it means that you recognize that this is a growing cohort of patients. We're lucky and grateful to be joined by Dr. Claire Curtin, a specialist in special care dentistry. Claire graduated from University College Cork in 2007, after which she specialized in special care dentistry, and having held a consultant role in Cardiff University Dental Hospital, she returned to Ireland in 2021 and now works as a senior dental surgeon in Cork. So just a couple of housekeeping, just so that everyone is aware of the functionality of Zoom. The Q&A box is at the bar at the bottom of your screen, and you can ask questions throughout. You can feel free to share your perspective in the chat box as well, your experience with your patients and little tips that you might have. And then we can discuss them during the end of the session. There's also a functionality where you can raise your hand as well if you'd like to say something verbally to Claire at the end of the webinar as well. And that's pretty much it. So without further ado, I'm going to hand the stage to Claire.
Thanks very much, Ahmed. Can you hear me okay?
I can hear you well, thanks.
Yep. Okay. So just stop me if there's any problems as we go along. Firstly, I'd like to say thanks very much to the committee for asking me to do this webinar. It is a topic that I'm really passionate about. I mean, I love working in special care dentistry in general, but the care of older adults, and specifically older adults with dementia, is something that I'm really, really passionate about. And I genuinely believe this cohort have faced huge barriers to care across all parts of the healthcare. And I think with just a little bit of education and a little bit of confidence, they can be treated, comfortably and well in general practice even. So hopefully it can just give you a little bit of insight into what dementia is and how we can make small changes to practice to help these patients receive good oral care. So I'm trying to get this to move now. There we go. So just the learning outcomes for this evening. I'm going to talk about the different types of dementia and stages of dementia just briefly, because that actually is important. Knowing the type of dementia that the patient has will give you an insight into maybe behaviors that you might expect, and maybe how their disease will progress will help you planning as well. Then we'll look at the challenges associated with treating these patients and how you can maybe overcome these challenges by providing some dementia-friendly dentistry, and then also how to provide particularly safe and appropriate dental care for them. So just before we start, I'm going to talk about a patient that I remember seeing as a new graduate working in general dental practice when I had very little special care experience. And I sometimes think back on her and think how I would have treated her very differently had I seen her later in my career. So I just want you to think about, maybe if you had this patient come into your practice, what would you do now as regards treatment? So she was a 70 years old retired actress. She was a very glamorous lady, was still very glamorous when she came in to see me, in the middle stage of Alzheimer's disease, not complaining of any pain, but her husband was her carer and he'd noticed bad breath and bleeding gums. He was trying to help her brush her teeth, but it was a struggle. There was limited cooperation. He was worried she wasn't eating very well. And when I saw her, she did have very stark halitosis. She had a minimally restored 7-to-7 dentition. Her oral hygiene was very poor. Stage 2 or 3 periodontal disease. The molars had about 50% bone loss. They were all a little bit mobile. It was just a very unstable periodontal status. So for her, what I did when I was a new graduate is I referenced my periodontal, how do we treat periodontal disease, and arranged for her to see the hygienist for, 4-quadrant scaling, or PMPR it was called now, and oral hygiene instruction, everything completed under a lay, 4 visits, and perio charting and pocketing and everything. And I just want you to think about maybe how you would treat her if she was coming into your practice now. And at the end of the talk, we'll have another think about maybe how that could have been changed to make things a little bit better for her. The care that I prescribed at the time, she didn't manage very well with. She found the appointments very difficult to manage. She was getting upset during the appointments. Keeping her mouth open was difficult. The hygienist was very stressed during it as well. So yeah, just bear that in mind as we're going through and think about maybe what we could have done instead. So like Ahmed referenced earlier in my introduction, why does it matter, dementia? Does it matter? I suppose it doesn't really matter if you're a specialist pediatric dentist, very unlikely to be seeing someone with dementia. But for the vast majority of dentists in this country and across the world, no matter what specialty you're in, you will be treating people who are living with dementia. So at the minute in Ireland, they're estimated to be about 64,000 people living with dementia. And in 20 years' time, it is estimated that that number will have risen to 150,000 people. That is a huge, huge increase. It is, as Ahmed also mentioned, linked to the increasing age of the general population as well. The population isn't, or the problem, or the increase in diagnosis of dementia is not unique to Ireland. In the UK, there's currently estimated to be about 850,000 people living with dementia. That's going to go up to 1 million by 2025 and will exceed 1.6 million by 2040. So it really is a diagnosis that's getting more and more common, and it's not a population that we can avoid treating. So what is dementia? It's a syndrome, usually chronic or progressive in nature, and there's usually a gradual deterioration in cognitive function. It's often thought that it's just memory that's affected, but it's not just memory. There's a wide, range of symptoms, and people experience dementia very differently. It doesn't affect your consciousness. It does affect how you think or plan or organize things, how you speak, how you choose your words, the judgments that you make, your visuospatial skills, and it does affect your memory as well. How is it diagnosed? Just for interest for you, if you have someone who is living with dementia, the sort of pathway they may have gone through is that there'll be a suspicion of cognitive impairment, whether they notice that themselves or their family notice it. It's usually a trip to the GP to have a history taken. There might be some cognitive assessment test done, a physical exam and blood tests. Usually the physical exam and the blood tests are to rule out some reversible causes of symptoms and signs that can mimic dementia, and I'll talk about those in a minute. Once those reversible causes are addressed, then you may go on to receive a diagnosis of either mild cognitive impairment of dementia, or you may get an uncertain diagnosis. And all of these terms, mild cognitive impairment and dementia, I will talk about now in a second. So the mild cognitive impairment is not actually a type of dementia. although people who are diagnosed with mild cognitive impairment are more likely to go on to develop dementia. The reversible causes that we talked about there, some drugs and alcohol can mimic some signs and symptoms of dementia. Some people can have depression, again, that can mimic some signs and symptoms of depression. Some nutritional deficiencies, the same story, and hypothyroidism as well. So those reversible causes would be addressed first before a patient was diagnosed with dementia. And the stages of dementia are generally described as early, middle, or late. Someone who's in the early stages would usually be living independently still, would have some mild functional issues, so mild memory loss, would need a little bit of support for daily living, but in general could still be living on their own. In the middle stages, these people will develop behaviors that may put themselves in danger, may not recognize dangerous situations, may wander, may need more support for daily living. And that when they progress on to the later stages, then communication reduces, mobility reduces, there's weight loss, fatigue, incontinence, and increased agitation. So generally people live between 5 and 10 years post-diagnosis. It depends on a lot of factors. It depends on underlying medical conditions. It depends on how early or late the diagnosis was made, obviously, as well. So there are 4 general types of dementia. The most common one is Alzheimer's. Then we have vascular dementia, dementia with Lewy bodies, and frontotemporal dementia. Mixed dementia is people who have both Alzheimer's and vascular dementia. There are more rare causes of dementia, such as Huntington's disease, Korsakoff syndrome, but I'm going to talk about the main 4 types today and how they might be relevant to the patients that you're seeing. So Alzheimer's disease is the most common. That occurs in about 60 to 65% of cases. There's a loss of neurons and synapses in the cerebral cortex. You can see from the picture there, in general, the cortex reduces in size, the ventricles will increase in size, and the hippocampus will shrink severely. There's deposition of amyloid proteins, neurofibrillary tangles, the acetylcholine receptors will reduce as well. So there's quite distinct features in the brain that occur with Alzheimer's disease. These patients that you will see in surgery will often be on medication to treat Alzheimer's disease. It's important to remember that dementia is not curable. Every patient will progress, but the drug treatment may delay that progression and give someone a little bit more time in the early or middle stages of the disease. Okay, so they may be on any of the 4 sort of medications listed there. Vascular dementia is again one of the 4 types of dementia, and there are 4 types of vascular dementia. It's relevant to know which kind of type of vascular dementia they have, because it may affect how the disease progresses for the patient. So people who get vascular dementia will also be the same people who experience heart disease. So typically these patients will have high cholesterol, high blood pressure, they'll be smokers, they'll have a history of stents being placed. Any sort of heart disease condition will put them at higher risk of vascular dementia. So post-stroke vascular dementia occurs when a large blood vessel is suddenly blocked. So 20% of people who have a stroke will develop dementia in the following 6 months. And naturally, increased number of strokes equals increased risk of getting vascular dementia. So a single or multi-infarct vascular dementia will occur when the medium or large vessels are blocked temporarily, and that can cause some brain tissue to die, and then that will affect the function of that part of the brain, and the patient may develop dementia as a result of that. Small vessel disease occurs when the vessels deep in the brain, they're not usually associated with having a stroke. When these vessels, the walls thicken and become stiff and twisted, and then you have less brain or less blood flow going to that part of the brain, and that may affect the function of those parts of the brain, again leading to dementia. And mixed is where we have several types of vascular dementia. The progression of vascular dementia is different to the others because if, for example, someone has a vascular dementia triggered by a stroke, they may have a stroke and go downhill very quickly in the signs and symptoms they're displaying of vascular dementia, and then be quite stable for quite a while. They may have another stroke or a TIA that will affect their brain function, and then they'll decline very quickly again. So it's almost more a stepped decline for them. Whereas if you have small vessel disease, that's less of a step decline and more of a gradual one that will occur. But these patients will often have a lot of comorbidities. So bear that in mind. If you're treating someone with vascular dementia, it's likely that they will have some heart disease, heart failure, atherosclerosis, high cholesterol, high blood pressure as well. So dementia with Lewy bodies is a dementia that shares symptoms of Alzheimer's, but also Parkinson's disease. So when these Lewy body proteins occur in the outer brain, it affects the cognitive functions, and the patient will have dementia with Lewy bodies. When these occur in the base of the brain, it affects the motor function, and the patient will have Parkinson's disease. 1/3 of people with Parkinson's disease will get dementia, and 2/3 of people with dementia with Lewy bodies will have motor symptoms similar to Parkinson's disease. And as the conditions progress, they merge really. Again, patients who have dementia with Lewy bodies may be on some medication similar to the Alzheimer's medication to help delay the progress of their disease. Frontotemporal dementia, this has been in the news a good bit recently, or the entertainment news, because this is the type of dementia that Bruce Willis has been diagnosed with. It's a less common form of dementia. The lobes involved are the frontal lobe and the temporal lobe. These are the lobes involved in behavior, emotion, and language. So actually in this type of dementia, the memory is not often the first symptom of the dementia. It may be behavior changes, patients acting impulsively or inappropriately, having no motivation or displaying suddenly very selfish behaviors. Or their language may be the first thing affected, in which case they might be choosing the wrong words, struggling to find the right words, or putting words in the wrong order. Patients who are diagnosed with frontotemporal dementia is generally a much younger age group, and there's a much stronger familial or genetic link to that, rather than the other forms of dementia. What's coming up next is a little video that I'm going to play. It's a video, it's freely available on YouTube, just from the patient's eyes, basically, of what it's like to go to an appointment as someone with dementia. I apologize if some of you have watched this already. I've seen it many, many times, and I still find it interesting. And it's a little bit heartbreaking, but a little bit eye-opening to see the small things that can make a big difference to someone's appointment. So I'll leave it play, and then we'll move on afterwards. So I know that video is quite long, but I think it gives a really nice insight into what it's like going into a dental practice as someone who's living with dementia. In that video, you can see how the noises and the visual cues trigger memories for her, and life is very confusing with flashbacks to the things she can remember when she was very young. The floor that looks absolutely fine to you and me looks like a puddle of water to her, and I'll talk a little bit now about how to make dentistry more dementia friendly. And part of it is to do with the environment and the noises that are around. Part of it is to do with rapport and how you communicate with people. The real star of that video was that dental nurse, and you can see the small things she did that made a big difference, bending down beside her to speak to her, repeatedly mentioning her daughter's name, who she knew that she was trusted and relied on her, helping her through and taking time to listen to her and reassure her throughout. So you can see the difference that just small little changes made to helping her get through that appointment. So we'll talk a little bit now about dementia-friendly dentistry. So the general considerations that I would say is that, be flexible. I'm actually going to go back a little bit, because what I want to do is highlight, first of all, the sort of awareness campaigns that are in different countries. So there's a really wonderful guidelines book from FGDP published on dementia-friendly dentistry, which is really, really comprehensive and available free online as well, if anyone is really interested in that. In the UK, the Dementia Friends program was one that I did when I was a specialist trainee, and it really, really changed how I approach treating patients with dementia. You know, for example, I remember one of the people doing the talk for us talked about how explaining how memories are lost for patients who have dementia. So, you know, imagine as you're growing up that every year you put down extra books in a bookshelf. So you start off on the bottom, the bookshelf down at the bottom, and you put in all the books there. And as you create memories and you get older, you start adding books to the bookshelf, and you have to move up and up and up the bookshelf. When you get dementia, that bookshelf starts to shake and become unstable. And the first books lost are the ones up near the top. And they're the ones of the most recent memories. So it's a good analogy to think of that those books that are lost are the ones that are the most recent memories. So patients will like to talk about things that happened in their childhood because that's what they remember. In Ireland, this talk is actually quite timely because I think it was last month, the HSE and understandtogether.ie and Dementia Pathways all work together to create this dementia inclusive community badge that healthcare professionals can work towards getting, and it's a badge that you can display in your practice or in your HSE clinic to show that staff there have received some training and are aware of dementia and are happy to help people with dementia. All those resources are free online as well, so it's a really nice thing to look at if you're in Ireland. So we'll talk about general considerations. If you are seeing a patient who is living with dementia, then there are a few kind of general things that you could think about doing. So flexibility is really, really important for these patients. You could have a patient in one day and get, you know, 2 or 3 fillings done and everything's going great and they're in a really good mood and everything's happy and everything goes well. And they could come in the following week, you could do the exact same thing and they're just having a bad day and you get nothing done. And on those days, it's better to accept that actually this isn't the day for it. Accept what you can get done, and what you can't get done, move on to another appointment, because pushing it will likely create tension. It will get the patient worried, you'll be stressed, and you've broken that relationship, and it'll be very difficult then to get that patient back into a good routine of coming into you. There's a few things that you can do finding out in advance that will help you as regards, you know, seeing this patient at the best time for them, on the best day for them, with the best person for them. So it may be that they have a daughter who takes them to all their healthcare appointments, and that daughter knows how to help them and support them. So it'd probably be better to arrange to see that patient on a day the daughter can come, rather than maybe a carer from the care home who might not be quite so good at helping the patient receive care. The timing of appointment is important. So often patients do better in the afternoon. Early morning appointments are usually not a good one for patients with dementia. Try not to keep them waiting. The same as what we would say for, you know, our younger patients with autism or anything. Keeping them waiting for a long time will just make them more anxious. They're out of their normal place. They're in a strange place, and just hanging around a waiting room with other patients and things will likely just make it even more anxiety inducing for them. You can see in that video that I just played that Barbara there thought she was seeing one dentist. Then the receptionist said, oh no, it's taken over by another dentist. No, actually you're seeing a third dentist. And you can see her face get really anxious. And she's like, oh, but I thought I was seeing this. So even though these patients don't specifically have great recent memories, the continuity of care and seeing the same faces is still important to them. So a routine of going to the same surgery and seeing the same dentist, aside from the fact that that dentist will know that patient and the patient's care, the patient's family, and things will be easier from that point of view. Also being in the routine of going to the same surgery and having the same place to sit down will also help the patient accept some treatment. Access is important. You know, ground floor surgeries are obviously going to be easier. Space for a Zimmer, space for a wheelchair. I mean, if your surgery is not wheelchair accessible, it doesn't mean that you can't see someone who is living with dementia, but you know, as time goes by and their dementia progresses, they may well need some accessible surgeries. Again, in that video, you can see some triggers for the patient, so noises, different visual cues. Sometimes there can be memories triggered from different genders, and maybe that patient will need to either see a male or a female dentist. Again, this sort of information can be gotten in advance if you have a chance to ring the carer or ring the daughter or son beforehand and just find out, you know, I understand your mom or dad has dementia. Is there anything in particular we can do or avoid doing to try and help him or her accept some care? The environment is also something that can be looked at. So there is lots of guidelines around and how you can make the environment better. And if you're updating a clinic or moving to a new PCC and a HSC clinic, then taking that opportunity to make small changes to the environment to try and make it a bit more dementia friendly is worthwhile doing. There is some very basic things that can be done. For example, in the video, you saw that flooring with a pattern on it, it looked like a puddle of water to Barbara, but it isn't. But it's important that if you're going to make something dementia friendly, that you pick plain flooring, nothing that has a pattern on it that would be confusing. For example, if you're putting up signs, have the sign on the door rather than beside the door. If you're putting up a sign for something, have it on that something rather than beside the something. So it's very, very clear what it is and where it is. Having good contrast between the writing and the background. There's lots and lots of basic things that can be done that will make it a really, really more accessible environment for patients with dementia. And this dementia-friendly checklist is from the Dementia UK website. So again, like I said, finding out in advance will certainly help you treat these patients, but also there are things when you're taking the history that you can ask about that will also give you an insight into how you might treat this patient or things you have to take into account. So when you're taking a medical history, it's worth talking about whether the medicines they take, are they tablets or are they liquids? As dementia progresses, a lot of patients in the middle to late stages will also develop dysphagia, which is a difficulty in swallowing. And that's relevant if you're going to provide treatment for them. So finding out how they accept medicines, tablets or liquids. Do they take thickeners in their fluids? In which case, do those thickeners have a high sugar content? A lot of them do, in which case their caries rate and their risk of caries is very, very high. Like I mentioned, if you knew they had dysphagia, then you'll need to adapt your oral hygiene advice that you give and also will adapt how you treat them. And I mentioned earlier with vascular dementia in particular, they may have many comorbidities, and that is relevant for how long, I suppose, they expect this disease to progress. And also when you're planning treatment or extractions, it's not just the dementia that you'll have to manage, but also their medical conditions behind the scenes. A dental history and getting a good dental history is really, really important because this is a really good predictor of how well they will accept dental care. So someone who was a regular attender, who was really meticulous about brushing their teeth, who went to the dentist a lot and didn't have any bother going in, will probably be absolutely fine for quite a while during their dementia because it's almost like a muscle memory. They're used to going to the dentist and it's just something they almost do without thinking. Whereas someone who never attended the dentist, who was really, really anxious, attending the dentist and only went if they were having a massive swelling or pain, then they're unlikely to be a very good dental patient with dementia either. So it's worth finding out their history. It's worth finding out their past preferences, what kind of choices they made for their dental care. And also it's worth finding out what kind of support they have at home. Do they allow someone to help them? Do they need someone to help them? Are they doing a good job at home themselves? Or do you need to include the family or carers in how their oral care is taken care of at home? So that links into social history, finding out the support at home, getting a feel for how important they believe dentistry is and oral care is within the family. Is it a priority? Isn't it? How easy is it to get to appointments? Are carers doing oral care? Is it family? And finding out a next of kin. I'm not going to talk about consent and capacity in this talk because it's such a huge issue, but it's so different across different countries. But it's worth finding out a next of kin as well for any decisions that need to be made. They may need to be consulted. So for treatment planning, the overarching and the most important thing that you can do for someone who has dementia, especially someone in the early stages of dementia, is to implement a really, really good and effective preventative regime. These patients really become, it becomes very difficult for them to accept dental care in the later stages. So what we want is to implement a really good preventative regime in the early stages, so that we're not facing a situation where we have someone with dementia in the late stages of dementia who has a huge amount of decayed teeth or a huge treatment need. So there is some rapid evidence summaries done back in 2017, which show that there isn't a huge amount of evidence or high quality evidence around patients with dementia and oral care, mainly because of ethics around consent and these patients participating in research. But it did show that, patients with dementia in community and institutional settings may have higher plaque accumulation, more teeth and surfaces affected by dental caries, and more extensive periodontal disease compared to controls, which I think anyone who treats people with dementia would agree that that is in general what happens, So prevention is just so important. If you achieve nothing else, but you get a really good oral care regime going with the carers and with the patients, then that is a really good success. There is some good evidence to show that brushing with chlorhexidine and using chlorhexidine as part of an oral care regime will help reduce the plaque and will improve their oral health, and also possibly reduce the incidence of pneumonia in patients who are frail and older. So that's something to consider as well when you're planning preventative care for them. So what do you need to recommend? So essentially, you need to get families or carers on board. The diet is going to be a really big challenge, and there's a part of me that feels that someone who is in, the middle and late stages of dementia, trying to change a diet for someone of that age and with everything else going on is next to impossible, and is just going to create stress for the family, going to create stress for them and for you. So, make whatever changes you can, and they're reasonable for sure. But we need to just focus really on getting toothbrushing done and getting fluoride on teeth. So all of these patients should be prescribed high fluoride toothpaste where possible. Obviously 5,000 parts per million is not available in Ireland at the minute, but 2,800 is. They should be getting fluoride varnish up to 4 times a year. And mouth rinse is not something that I usually recommend, mainly because a lot of patients swallow it. And I would be far happier if those patients were just brushing their teeth a few times a day instead. So in general, mouth rinse is not usually recommended, but high fluoride toothpaste is certainly recommended, and fluoride varnish up to about 4 times a year. There's a lot of videos online that you can use, and you can direct patients and carers to show them how to clean the mouth. A lot of questions that are asked from other dentists who are seeing patients with dementia is this worry that if they put on fluoride varnish on frail older adults, that they'll have fluoride toxicity and they for that reason do not put on the fluoride varnish. And I've just put this up just to show you exactly how much fluoride they would need to have to reach the toxic level. So Durafat varnish, the usual amount per adult is 0.75 mL, which is equivalent to 16 milligrams of fluoride. So the toxic dose is 5 milligrams per kg. So the patient would want to be 3 kg to have any toxicity from Durafat varnish. Similarly, Durafat 5,000 parts per million toothpaste, the recommended amount is a 2 centimeter ribbon. In reality, we're telling patients to use a pea-size amount of that. That contains about 3 to 5 milligrams of fluoride. So this just won't be a toxic dose for these patients. Please don't be afraid to use it on them. But what you will do is help prevent them needing dental care as you go forward. Another thing that comes up quite a lot is whether dentures should be stored in water or not. There's a lot of chat about if we store them dry, will they warp? I think the evidence now shows that they really won't warp to any significant degree or any clinical relevant degree. However, if we store them dry, there are lots of benefits. There's reduced biofilm, there's reduced candida albicans, And it's just much better for the patients, especially if they are in care homes. There are plenty of care homes that I visited where the water has not been changed for a week or two, and the denture is being stored in water that has been there for 7 to 10 days. It's much better to just take the denture out, clean it, and leave it dry overnight. So we're coming on to the last little bit of the presentation now. And when you're seeing patients for dental treatment specifically, what are the things you should take into account when you're planning care for them? And if you remember nothing else while you're treating patients, it's basically the mantra of high quality and low maintenance dental care. You need to plan for decline. Even if you're seeing a patient who's coming in and they have early dementia and they seem absolutely fine and they're flying it and they're feeling great and their family are delighted with them, they will decline. That's what we do know. If they have a diagnosis of dementia, they will decline, and we need to plan for that. You know, having hugely complex mouth, you know, full mouth rehabilitation, advanced restorative treatment. If you are planning that, then you really need to consider how that will be cleaned and maintained as the patient progresses through dementia. And it's not an easy decision, and it's not an easy treatment discussion to have with patients, but it's important that we have it early on in treatment plans. If you're making dentures for patients with dementia, they should have a simple design. Are they easy to clean? Do they really need that denture? Is that another thing to clean in their mouth? Could you do a shortened dental arch instead? Will they cope with a new denture? You know, if they're not going to cope with the new denture, could you do a copy denture for them instead? For patients who are repeatedly losing dentures, it's a good idea to take a putty impression of a new denture when you give it to them and keep that in case they lose it again, and you can quickly get a new denture made that is a very similar shape to their last one. Okay, so if nothing else, high quality, low maintenance dental care for these patients. In the moderate to advanced stages of dementia, this is quite variable depending on what they can manage. Treatment in general practice, if possible, again, high quality, low maintenance treatment, and be realistic and consider the broader picture. Always in the back of your head have, how will this be kept clean when this patient is dependent for oral care? Okay, consider atraumatic restorative techniques, stabilization. Consider whether the patient can actually cope with having comprehensive treatment, or whether it should just be symptomatic treatment or more palliative dental care. So all of this has to be discussed with the patient's next of kin and the patient's family, that, look, you know, this is now at this advanced stage of dementia and we don't want him to be in pain, and we can treat this by doing this and covering this and adjusting this. And we know he has other, you know, problems in his mouth, but at this stage, we probably just should treat symptomatically. And if they flare up, we'll treat them. And if they don't, we'll accept that just dental treatment is a little bit too stressful for him and a little bit too much for him to manage at this stage in his disease. Okay, there's a lot to be said for domiciliary care for patients who are in advanced stages of dementia as well. You're seeing them at home, you're seeing them in an environment that they know and they're happy in, and they have their own family or carers around, and you'll often find that people will cope better with dental care in their own home. However, we are very limited in what we can provide in domiciliary care. Capacity and consent is obviously something that will have to be considered as well, depending on what is relevant in your area. So there's a lot of things about patient management and challenges that you may come up against. And I understand treating patients with dementia, it's not particularly anxiety inducing for me, but I know for some dentists that would really be something that would ruin their day. You know, and the unpredictability of the patient, family having unrealistic expectations, there's comorbidities to manage, and then there's developing rapport as well. So there's a lot of things to consider when you're dealing with the unpredictability part of things. Again, like I mentioned earlier, trying to speak in advance to the family will give you a good idea. I remember when I was working in Wales, I had a patient who was a professional boxer, and he used to hit out quite a strong punch when anyone came near him. Now, happily for his carers and his dentist, he had had a stroke, so he had left-sided weakness, so he was not able to punch people with his left arm, in which case I was standing on the left when I was seeing him, while his carers stood on the left when they were seeing him, because that was safer for all of us. But if you hadn't asked that or talked to the family, you wouldn't have known that, and you would have found out very quickly that the right side was not the right side to be standing on. Okay. Simple things that you can do. Patients often like to be sitting up rather than lying flat on their back. They don't tolerate lying back. Position whoever they came with. If they like that person, if it's their family member or the carer that they trust, make sure that they're in their eye line. Move their chair so that the person with dementia, when they're sitting in the dental chair, can see the person that they trust ahead of them. And they have that constant reminder that they're safe and there's someone looking after them. And we saw in that video where that dental nurse nicely kind of crouched down beside Barbara to talk to her, held her hand, reassured her, smiled at her. All of those things make a really big difference. Try to manage your own anxiety. If you're stressed and you're worried and you're fussing around, that will project onto the patient and they'll start to get stressed and the whole thing will start to break down. For actually getting in to see a patient's mouth where maybe there may be trouble, trying to get a mirror in there, consider using a toothbrush and just say that you're going to brush your teeth. Maybe ask the carer or the family member to bring their own toothbrush and their own toothpaste with them. And you can start using a toothbrush, get the nurse to hold the light and try and see what you can see when you get in to brush their teeth. Sometimes you got to admit defeat and it's not your day or it's not their day and you try again. But reflect on maybe what you could have done differently and try something a little bit different the next time. When talking about unrealistic expectations, this is a really challenging situation to manage as well, because oftentimes family members will come in and they'll say, oh, she's not eating, she's losing weight, her dentures are loose, and if we could just make her better dentures, then she'll be eating again and then she can put on weight again. And the unfortunate reality of this is that this is the progression of the disease, that their ability to eat and get nourishment reduces and they start to lose weight and they start to lose muscle and protein, and it's natural for that to happen. But sometimes families get an idea in their head that if we could just fix the dentures, that would fix everything for the patient. And that's a very difficult thing to say to someone, that actually, look, they're not really going to cope with how to make the denture. It's actually quite a challenging thing to make. And B, I don't think they'll be able to wear a new denture. I don't think they'll adapt to it, because denture wearing is a learned skill. And it's very difficult to learn a new skill in middle or late stage dementia, if not impossible. So what can you do for a difficult situation like that? I'm not an expert, but generally what I would say is you have some options. If we reach an impasse and I'm saying, look, I don't think they're going to manage, and the parent or the son or the daughter is saying, look, I think they will, then I'll invite them along to the appointment to see how we get it done. And oftentimes I think people underestimate how challenging it is to get a denture made. So when they see how difficult it is to have the impressions taken and bite registration and everything, oftentimes they say, look, actually, I don't think she's managing. And I'll say, I don't think she's managing either. This isn't helping her and she's stressed about it. And sometimes wearing a copy denture can reduce some of the impressions and things that need to be made. So if you have a denture that's just a little bit loose and looks fine, and it's a full denture, then a copy denture technique is one way as well of trying to get around those problems. This is a final little piece, is just a developing rapport, and something that always sticks in my head is the saying that they might not remember you, but they will remember how you made them feel. And that is important. These patients will remember what happened in their childhood or their earlier life. Listen to them. They may mention someone or something they like to talk about. And it's important that you go with them, chat about what makes them happy. I remember in Wales, this lady was so proud, obviously, of her dad who fought in the World War. And I have absolutely terrible knowledge of any World War, especially, the level she was talking about. And every single time she told me about her dad who fought in the war, we had a big chat about the war, and she loved talking about it. She lit up talking about it. I hadn't an absolute notion what she was talking about or the details of it, but it really settled her. In every appointment we had a chat about the war. I've had another patient who loved to sing, and before he left the surgery, every time he had to give us a song, and he was delighted with himself. We had a little song before he left, and he left happy, and he'd return again. So you have to go with them, whatever's going to make them happy and help them settle in your surgery, then try to go with them as much as possible. Okay. When you're communicating with them, stand in front of them, be at their level, one thing at a time. Try not to overburden them with information all the time, you know. Ask them to sit down first, then I'm going to move the chair. Try not to give them a whole list of information together, because it's quite overwhelming. Okay. So the last little video, this is only a minute long. This is a lady who's diagnosed with Alzheimer's disease, age 63. She's just talking about how it's better to connect and don't correct. So I'll play that for you, and then we're done. So yeah, I think it's just it's nice to hear from I suppose firsthand experience. For those of you listening from the UK, someone getting cross with someone is someone getting angry. It's quite an Irish phrase. But she can show that, you know, just going with it. If there's no reason why you should be arguing with someone, the day isn't the day she thinks, if it doesn't really make a difference. So my final bit is about an emergency appointment, and this is also something that can be quite anxiety inducing, that you have maybe a patient with middle or late stage dementia who can't really give you a huge amount of information about what's wrong or how they're, or what pain they're in, but you're being called out because the carer thinks it's a dental problem. A few kind of questions that might help you decipher whether it is a dental problem is not to ask about behavior change. So are they eating, drinking, or sleeping differently to what they were, for example, last week? Are they now refusing the ice cream they always ate? Are they refusing, you know, cold drinks? Or are they refusing hot drinks? Are they waking up at night when they used to sleep absolutely fine, you know? So it's important to find out behavior that has changed. You know, are they requesting pain relief? Are they refusing toothbrushing? Are they wincing when you're brushing one side? Is their behavior out of the ordinary for them? If the carers or family aren't sure and you're not sure after doing an exam, then asking them to keep a pain diary would be really helpful. So when did the patient look like they were in pain? When were they, you know, wincing? When were they asking for pain relief? This sort of thing. And then you can review it after a few days and decipher whether it really is a dental problem or not. Again, what if treatment isn't possible? Not uncommon in advanced dementia. It's better to try non-pharmacological methods first. So, you know, try ART or minimally invasive dentistry, temporizing teeth, using, you know, SDF if that is something that they'll tolerate, using glass ionomer, using fluoride varnish. Sometimes pre-medication prescribed by the psychiatrist or GP can help just to relax them a little bit. Sedation and general anesthetic would be very tricky for these patients, but not impossible. But that would have to be fully discussed with them about the risks and benefits, and would certainly need referral to secondary care for that. And as I mentioned earlier, palliative dentistry, just treating them symptomatically if needed. So again, this patient, and this is the last piece I'll talk about, if I had my time again, I would treat her entirely differently. We would have a big, you know, a chat with her husband about realistically what we can achieve. If there were teeth that were very poor, and I mentioned they had quite 50% bone loss and were mobile, then I'd consider maybe taking some of those teeth out if they were very mobile, rather than trying to hang on to them no matter what, which is what I did when I was a new graduate. I would have looked at adapting the appointments for her, shortening the times, having a really realistic chat about what was achievable for her and what was comfortable for her to achieve, rather than just going by the strict guidelines of we must treat the periodontal disease. I would have done a much more holistic assessment of what her case was. And that's me all done. I've ran over a little bit, I'm very sorry, but I'm happy to answer any questions.
Fantastic. Thank you so much, Claire, for that. That was very interesting. Lots of thought-provoking advice and tips, and I really loved how you went full circle with that case. I thought that was really, really nice, because we all have those cases, don't we, where in our past less experienced selves treated one way, and you know, after having been to a webinar such as this or attended a course, on reflection, you might do things kind of differently. And I suppose it's all about planning ahead, thinking about the future. And the future of people with dementia is very different to how you might see them now, as opposed to someone else. So yeah, really, really interesting. Thank you. We have a question here from Olivia. Do you, by the way, if anyone else has any questions, if they can please put them on the Q&A chat box now. Do you advise not wearing dentures when the carer is not comfortable taking it out? This is coming from a patient whose husband was caring for her at home and wasn't removing the dentures between dental hygiene visit appointments every 3 months.
I would say you need to explore why he's not comfortable taking it out. Is it because she finds it painful, or is it too complicated? Is there something to do with the design that you can change to make him comfortable, or does he just need a bit of practice and support? If the denture isn't being removed for 3 months, then definitely leave it out, because there's just candida and all sorts festering underneath that, and that's just going to make things worse for the patient, because they'll get worsened perio disease, they'll get infections and caries. So I would say try and explore why it's not being taken out and try and adjust the denture to make it more accessible, and if not, I would say leave that out.
Lovely, thank you. Have you experienced with intraoral scanners in people with dementia in terms of coping with impressions and remaking dentures and something along those lines?
I haven't had the pleasure of intraoral scanners, but I know Danny has put on the chat there that she probably has.
Yeah,
it seems like it would be hugely beneficial, because the biggest issue with making, well, I suppose the biggest issue with making a denture is the bite registration phase, trying to get someone with, you know, middle stage dementia to understand how to bite in a reproducible position is very difficult. But I would imagine intraoral scanners would really help the situation. Sadly, the HSE in Cork or Cork University Dental Hospital have not invested in such thing yet.
I don't know, Danny, if you have anything else to add to that, but I have another question in the meantime. What risks are there for patients with dementia undergoing GA? Our anaesthetists much prefer IV sedation and local anaesthetic. Yeah,
the risks are much higher for patients with dementia because of their age and because of the dementia. They are much higher risk of a much of significant worsening of their dementia after the GA, a much higher risk of experience delirium afterwards, but progression of the dementia is a really big risk. Coupled with the fact that they're frail and older, and the risks of GA and not surviving the GA would be higher as well. So generally it would be IV sedation that would be preferred, exactly like your anaesthetist said. And it may be that a patient would need maybe 8 or 9 teeth done, but the decision would be made to just treat the tooth that's causing pain under IV sedation, rather than putting them under a GA for the treatment of all 8 or 9 teeth.
Thank you. Have you any tips for optimizing provision of care for dementia patients in the care home or a long stay hospital setting?
So there are some nice, it's very difficult. It is, you know, because actually you'll find that carers will often prefer to be cleaning feet than they would teeth, you know. It can be very difficult to get people on board. There's a lot of programs in the UK, you know, Mouth Care Matters and Gwen and Beth in Wales that have oral care assessments that can be filled out daily to show that it's being done. I think the key is to get an oral care champion, someone who is on the staff who is really enthusiastic and very well trained and is there as a support for the others then to help. But it's mainly to do with training and building their confidence in how to care for the patients. So you could use some of the videos that are linked, or the guidance documents that are linked to Mouth Care Matters online as well, which are really, really good. Or the video from BSG that I linked is a really good video for carers to watch as well.
Thanks, Claire. One more question we have time for. What's the role of SDF in caring for dementia patients?
So I don't use it at the minute, simply because I am not sure of its applicability for dementia patients. Repeated applications and having to isolate appropriately and getting them to sit quietly for that is challenging. So I know that the evidence is really good for older adults with root caries using repeated applications of SDF. I'm not aware that that same evidence exists for dementia, and the ability for them to, like I said, repeatedly sit, have it isolated, and get the SDF done is limited, I think, in my hands at the moment. However, my use of SDF is quite limited in Ireland. I don't know if you've used it, Ahmed, at all.
Yeah, I did use it in Dublin when I worked there. SDF has a certain protocol for its use, and that can be technique sensitive and require quite a bit of patient cooperation. However, a lot can be said for kind of splodging it on a tooth and covering it with fluoride varnish immediately after. And that's generally what I did for adults who couldn't cope with the full protocol, because something is better than nothing, and that something is better than fluoride varnish. So that's how I used it. In patients who couldn't cope, I would apply it with a bond brush and cover it immediately with fluoride varnish and leave it there. So there is a role, I think, but you're right. The evidence for it in patients with dementia is limited. Older adults.
I'm not sure we ever will get the evidence either, because ethics of including them in trials and things is very challenging. So I think we'll just have to keep an eye on it as the use of it expands, I suppose.
Danny just mentioned, I commented on the relation to 3D scanning. Really nice to make dentures with the scanner, and then all the scans are saved, and some labs will be able to go straight to try-in or 3D printing used, then the denture can be reprinted. And I suppose that also applies for kind of if dentures are lost or broken, it can be simply remade because the scans are there. But that's it for the moment. Thank you again, Claire, for a fantastic webinar. Thank you everyone for attending. I encourage you to become members of the ISTH so you can gain access to all of our past webinars and also get updates on the next webinars. The next one's scheduled later on in the year after summer, and that'll discuss the role of vital pulp therapy in special care dentistry. Also, becoming a member will allow you to receive a discount to our summer conference. And I'm just going to pull up that here. On that note, the registration for the summer conference in Ireland is open, which is great news. So this year's conference will be held in the cultural capital of the country, in Limerick, in the Strand Hotel, and it'll be held on Friday the 9th of June, and there'll be a pre-conference on Thursday the 8th of June discussing sedation and treatment planning of sedation in special care dentistry. So this is the program. So I would encourage you all to log on to our website and have a look at the program if it interests you to become a member, because it will be cheaper if you become a member and register for the conference. And I will leave you with that. So thank you once again, Claire, and thanks everyone for attending. That is all. Gurv Magat, and goodbye, everyone.